Good afternoon to everybody. And the topic which is very important for this session is low HDL, high triglyceride, a real challenge in India. There are so many challenges in India. To live in India itself is a challenge, and dyslipidemia is no bar of that. So let's see how we can get away through dyslipidemia, which is seen in Indians. We know that prevalence of coronary heart disease has been increasing in India ever since 1960. And it has touched now more than 12-13%. Depending upon the subset of people we analyze, the rate is a bit different, but it is in double digit, no question, wherever we analyze anybody from or any set of Indian patients. Now there are a lot of facts about Indian coronary artery disease, that we Indians have a lower rates of conventional risk factors, but CAD rates are amongst the highest in the world. The prevalence is roughly 2 to 4 times higher than the rest of the world, and unfortunately it occurs at a very young age. And average age of first heart attack is 10 years younger in Indians as compared to Western people. If we do angiogram, we see greater severity of multiple blocks. Now it's becoming common in females, and unfortunately again, size of heart attack is on an average larger with the Indians, and there are more complications of MI. So bad coronary artery disease is contributed by so many factors, and one of them, and one of the most prominent factors, is dyslipidemia. The pattern of dyslipidemia which has been seen in Indians is a bit different, and we are characterized, or our dyslipidemia is characterized by high triglyceride levels, low level of HDL cholesterol. Overall LDL cholesterol may be normal, near normal, upper normal, but the proportion of small dense LDL cholesterol is high. This is called as atherogenic lipoprotein phenotype B, and this is dyslipidemia in association with metabolic syndrome and certain newer risk factors like lipoprotein little a, fibrinogen, homocysteine, increased thrombotic activities, etc. They all produce this bad disease. There are few large nationwide data and series available, but overall if you look to the prevalence of dyslipidemia, the hypertriglyceridemia is seen in non-obese as well as obese people. So even non-obese Indians are not spared of hypertriglyceridemia. And even slums and lower socio-economic status people do have prevalence of dyslipidemia. This one study which indicated that if you look at all the factors of dyslipidemia in India, low HDL is one of the commonest factors seen in most of the people, more than 60%. A famous study done by Anas, we all know that coronary artery disease in India, he suggested optimum HDL cholesterol is had by just 5 to 15% of Asian Indians. So roughly 80-90% of people do not have optimum level of HDL cholesterol. We have elevated level of lipoprotein little a, which is one of the commonest risk factors in Indians. It's highly atherogenic and is responsible for premature coronary artery disease. So genetically, the level of lipoprotein A is decided, and we cannot do much to the level of lipoprotein A. And in this particular study, it was seen that Asian Indians, 75% of them have atherogenic phenotype B. So that's a serious dyslipidemia, widely prevalent. What is the meaning of small dense LDL cholesterol? Your cholesterol level may be same as others, but the number of particles is more, and every LDL cholesterol particle does carry ApoB, which is highly atherogenic. So total ApoB is much higher even at the same level of LDL cholesterol. The small dense LDL particles are amenable to oxidation, engulfment, and they are less amenable to clearance, and that's why they increase the risk of CHD. Triglyceride itself is an independent risk factor for cardiovascular disease, which has been very well seen, and meta-analysis of 17 trials have clearly proven that yes, if your triglyceride is high, your risk of coronary artery disease is high, more so in female as compared to male. And similarly, HDL itself, low HDL itself, is an independent predictive factor or risk factor for development of coronary artery disease. We have seen so many trials in today's world where we are quite LDL centric, rightly so because of data, we are quite statin centric. All the trials if you take which use 80 milligram dose of atorvastatin, may it be PROVIT, may it be IDL, may it be TNT. If you look, 80 milligram dose of atorvastatin did lead to significant reduction of endpoints, but it is clinically inadequate. Even in PROVIT trial, those who were treated by atorvastatin 80 milligram, roughly 1/4 of the people did have various cardiovascular events in 2 years, and in IDL and TNT, maybe 8 to 12% that did have. So in spite of atorvastatin 80 milligram, people continued to have problems, and such high residual risk can partly be explained by lipoprotein abnormalities other than LDL cholesterol. So that's a very important point to understand. And the analysis of these two trials, CARE and LIPID, in which high dose of statin was given, after those patients who received statin, pravastatin, their triglyceride level was plotted against cardiovascular events, and it was suggested that with the increase in triglyceride level, there is increase in cardiovascular risk. So this is even after treating the patient with statin. So what is the treatment approach? It's difficult, but let's see how we can do away. So first and most important is we need to look for the cause. Is there a cause for hypertriglyceridemia and low HDL? We need to correct it. We need to implement therapeutic lifestyle changes which has a variable role, and we need to use medicines, maybe alone, maybe combination. So we know there is a huge list of secondary causes of hypertriglyceridemia and low HDL. We need to correct them: overweight and obesity, physical inactivity, type 2 diabetes, cigarette smoking, very high carbohydrate intakes, certain drugs, etc., etc. And we have to always work on that. Now, what is the importance of lifestyle modification? Lifestyle modification does help triglyceride to a good extent, but HDL may not be helped to that extent. HDL is somewhat resistant. But still, say those who are obese, if they lose weight, every 3 kg of weight loss is accompanied by 1 milligram per deciliter increase in HDL cholesterol. So weight reduction is a very important point for those who are obese. Smokers have low level of HDL, so once a person stops smoking, within 2 months, HDL level comes to the basal. And aerobic exercise increases HDL cholesterol in dose-dependent manner. Mind well, this is very important, and let's see what is that. Exercise has been to some extent overrated for increasing HDL, because exercise, there are 2 requisites. Number 1, it increases HDL only when triglyceride is high. People with moderate or normal triglyceride, perhaps exercise may not increase HDL. The response of HDL to exercise is very variable, person to person. And secondly, HDL is increased only with very intense, frequent exercise, which has been proven on data. So you need to be exercising 60 to 90 minutes per day, quite intense, perspiring a lot, and almost 6 to 7 days a week. Unless this, your HDL is not going to increase. So once after taking dinner, you go around with your wife, that does not improve your HDL cholesterol. Alcohol does improve HDL cholesterol to variable extent, but there are so many issues related with alcohol. We all know that it is not the binge drinking, it is not the occasional drinking of large amount, it is the almost daily drinking of small to moderate amount which helps. But there is a J-shaped relation between alcohol and variety of adverse health outcomes like CAD, etc. There are so many medical and social issues, and that's why we all know that now net effect of alcohol may be harmful in people less than 45-55 years of age, and so there is no merit in promoting alcohol as a preventive strategy as a whole, though it may increase HDL to some extent. So unfortunately, like every other disease, we are left with no other choice than medicines, and we have few medicines which can work on triglyceride and HDL. If you look at statin, they have effect on triglycerides, some of the statins, but effect on HDL is almost negligible. Fibrates effect on triglyceride is quite good, on HDL variable, but to some extent good. Niacin perhaps is the only molecule which has got significant effect on HDL, difficult to tolerate on high dose. And fish oil or omega-3 fatty acid does help triglyceride, improves HDL to some extent, but it may increase your LDL cholesterol also. So this is briefly, but let's see step by step. Can statin alone help the mixed dyslipidemia, that is high triglyceride, low HDL? We all know that potent statin like atorvastatin and rosuvastatin do reduce triglyceride to good extent, but the effect on HDL is not significant. If at all you need to work out on HDL by statin, you need to use either rosuvastatin or simvastatin. Unfortunately, atorvastatin, and that too when you use it in incremental dose, has a tendency to reduce HDL cholesterol. So my choice always in somebody who has HDL less than 35 is less likely to be on atorvastatin. One is to be concentrating on simvastatin or rosuvastatin more, but to a very low HDL less than 30, no statin can help. Fibric acid derivatives, they can increase HDL and reduce triglyceride. Variety of trials have been done. One of the oldest was Helsinki heart study, in which people with hypertriglyceridemia and low HDL were treated, and there was significant reduction in cardiovascular outcome. But there was increased non-cardiac mortality, which was not well answered. Veterans trial also did help by reducing cardiovascular events. So fenofibrate does help, and there is some angiographic regression data also. But the biggest question for fibrate is, In the present world, with huge statin data, only fibrate requiring patients are very few, because we know that a patient who has already coronary artery disease or vascular disease does need a small dose of statin. So if he has hypertriglyceridemia, low HDL, can we use only fibrate? That's a question, and perhaps the answer is not very clear. Nicotinic acid has got significant effect on HDL cholesterol. CDP was a good trial. 15 years data is now released, and it did show some improvement in cardiovascular event. But the biggest issue with nicotinic acid is variety of side effects. Like flushing, now we have certain combinations available where flushing is minimized. Hyperglycemia, making it relative contraindication to diabetic people, hyperuricemia, GI upset, etc. As I told you, CDP was the project done between 1960 to 1975, men with prior MI, and those who were given nicotinic acid at the end of 15 years, they had 4% absolute reduction in mortality. So yes, people with prior history of MI and with dyslipidemia may be helped by nicotinic acid, but this was an old data. So again, coming to the similar question, one major confusion for Indians with dyslipidemia is, can we treat them with fibrate or niacin alone? And this is a very important question. Can we treat our patients of dyslipidemia? Many of them may have vascular disease, CHD, diabetes with one of these. And that's why on most of the cases in Indians, we are land up with combination of therapy. And once there is a combination, multiple issues comes into play role. It increases the cost and complexities. It increases the risk of myositis and hepatitis. There are potential drug interactions, and there is overall less robust outcome data. We don't have too much data combining nicotinic acid and statin for long term. We don't have too much data combining fibrate and statin for long term, which has effect on coronary lesions or at least on cardiovascular hard endpoints. A relatively simpler combination, statin plus ezetimibe, which is quite well tolerated, has some additional effect on triglyceride but almost negligible effect on HDL cholesterol. So again, it does not help to the issue which we are dealing. Statin plus fibrate, as I suggested and showed, that small dose of statin with a small dose of fibrate is quite safe provided we do adequate monitoring. There is appreciable increase in HDL cholesterol as compared to statin alone, and HDL increase depends upon the baseline HDL. Those who have lowest HDL will have maximum increase. But again, as I told you, there are less number of outcome data. And perhaps similar is the story for statin and niacin combination. You can give the combination under monitoring. Reaching maximum dose of niacin is difficult, but you can chase, and one has to keep side effects in mind. Here's for a very important trial which combines simvastatin and niacin. A small dose of simvastatin with 2 grams of niacin. At the end of 3 years, there was significant improvement in dyslipidemia, which was associated with angiographic regression, prevention of angiographic progression and significant reduction in endpoints. So yes, we do have some evidence, which was small, 160 patients with CHD. There was a data with niacin plus statin showing that yes, when you give combination, the chances of carotid intima media thickness progression is reduced. So there is some data also. There is a data for statin plus fish oil. When you combine 2 grams of fish oil with statin, it does help. At least for secondary prevention, it has some effect on endpoints. We had so many novel ways in last 3, 4, 5 years, but unfortunately they have met with premature death. What was that? Torcetrapib, reverse transport inhibitors, and it was a big boom that yes, it increases HDL to a great level. People thought that some wonderful thing has come to our hand, but unfortunately torcetrapib died. It's a dangerous thing. Whether molecule itself is dangerous or mechanism, we don't know. Rimonabant, again there were big hopes, but banned because of a lot of psychological issues. Intravenous HDL therapy is under experiment and very costly. Maybe there will be someday we find it useful. So a lot of efforts are done to improve HDL, but nothing really works so well. So what is take home message, my dear friends, for Indian dyslipidemia? High triglyceride, low HDL, dense LDL is the chief problem in our country. No single measure is sufficient to correct this. Therapeutic implications are not as solid as they are for LDL cholesterol. That is a bit unfortunate. We need more RCTs, and comprehensive approach, including lifestyle modification and judicious use of drugs, is the need of treatment therapy. Thank you very much.